So I'm Alice. I'm one of the subspec trainees at Oxford Road in Manchester. We did an audit of pregnancies that have been complicated by sickle cell disease who have delivered at St Mary's. Just want to say thank you to Emanuela, Nikos and Louise Simcox, who all helped with this audit data. So I'll kind of rush to go through this because I've already had a very extensive talk about this. So sickle cell is the most common genetic disorder worldwide. Lots of people in the UK living with sickle cell, and as we've heard, it's a multi-organ disorder that gives us high rates of complications, unfortunately. In terms of pregnancies, it complicates up to 250 pregnancies each year. Majority of those tend to be in the big urban cities, as you would probably expect, so London, Manchester, Birmingham. And at Manchester, we've got a tertiary sickle cell unit that looks after patients there. And then within St Mary's, we've got a joint obstetric and red cell haematology clinic that looks after these women in pregnancy. We know that these pregnancies unfortunately suffer much higher rates of maternal and neonatal adverse outcomes. There was a UCOS data set that was run in February 2010 to 2011 that looked at pregnancies complicated by sickle cell disease. So they looked at both the homozygous, so the HBSS, and then the compound heterozygous, so your HBS plus C, D, E, O, Arab or beta thal sickle cell. And what they wanted to look at was what the current incidence of pregnancies with in women with sickle cell disease was, what's the management strategies that have been put in place for women with sickle cell disease, and including looking at blood transfusion and anticoag therapy, also the complications that are seen in these pregnancies, and then the outcomes for both the mum and baby. So over that 12-month period, they had 109 pregnancies complicated by sickle cell. They split the data between HBSS and HBSC, so just over half had HBSS. The mean hemoglobin at booking was 85, although as would you expect in the HBSS was lower at 65, with over half of women experiencing a painful crisis in pregnancy, again more in the HBSS women. 15% of experiencing severe pain crises, with almost 7% experiencing acute chest syndrome, with about 1 in 4 women needing an ITU admission and about 25% needing a blood transfusion at some point in the pregnancy. Although again, if you look at it in the HBSS data, it's more close to kind of 40-50% in those women. And again, just in terms of the background demographics, majority were from an African or Caribbean background, again, as you would expect. And then the pregnancy outcomes, so higher rates of your hypertension disease, again, and then the preeclampsia in particular in the HBSS women, almost an 8% rate of preeclampsia in these women. And then the cesarean section rates as well were so about 1 in 3 in the total group, but then it goes to half in the HBSS women. So the data that we looked at, so we wanted to kind of mirror the UCOS collection form, and we performed a retrospective audit of the sickle cell patients. And so we took over a 15-month period. So patients had completed pregnancies between April 23 and June 24. We wanted to look to see whether our data was comparable to the UK data, and then see if we could see any themes and adverse outcomes. So over that 15-month period, we had 21 patients living with sickle cell that had delivered. We had just slightly over half, so 62% had HBSS sickle cell genotype. Maternal age was 34 at booking with a BMI of 25, and then this slightly low normal blood pressure. And we had 1 woman out of the 21 that had a diagnosis of chronic hypertension, and about 1 in 3 were primiparous. And again, ethnicity, as you would expect, so kind of that 90% from a Black, African or Caribbean background, and then the rest being from an Asian Indian background. So antenatal booking HB slightly higher than the national average, so 95, but similar rates of sickle crises in pregnancy. So we had a 43% rate of sickle crisis in pregnancy. Our rate of acute chest crisis was 10%, so I'll go small numbers, so 2 out of the 21, and of those 2 people had a chest crisis. 1 out of the 2 needed an exchange transfusion. And then the pregnancy outcomes, so we had quite a high rate of preeclampsia, so 4 out of the 21, so almost 20%. The positive placental screen, so I'm going to talk about this a little bit later on, but that's what we were referring to, the uterine artery Dopplers that we assess at that 20 to 23 week scan to assess whether you're at high risk of developing preeclampsia or fetal growth restriction in the pregnancy. So in such a high rate of preeclampsia and fetal growth restriction, you would expect quite a high rate of positive placental screens, but it wasn't quite as maybe as high as you would expect. Again, the high rate of fetal growth restriction or small for gestation, only so 40%, so 8 out of the 21 collected had a baby that was growth restricted. This slightly lower gestational age delivery, so 37 plus 6, with this much higher preterm birth rate than you expect from a general population, so almost 1 in 3 preterm birth rate. And then this left shift towards the lower end of birth weights and birth weight centiles, and then 1 in 3 babies needing NICU admissions as well. And then the postnatal and birth outcomes. So out of the 21 women that we had, 2 had a vaginal birth. The rest had caesarean sections, so 10 had a planned elective caesarean section and 9 had emergency caesarean sections. When you look at the women that had emergency caesarean sections, so 6 out of the 9, so 2/3 of them had it for fetal distress, so kind of a 55% rate of Cat 1 caesarean sections in those women who were planning for a vaginal birth. Almost half needed some kind of HDU ICU admission. 3 out of the 21 had a postnatal VTE, and we had about a 1 in 4 rate of postnatal pain crisis as well. So themes are identified. So we had quite a large cohort of patients within that time period. We are ongoing audit collecting, and we're getting more patients every year, but we've got quite a significant amount of sickle cell women with who are having pregnancies throughout the UK. We felt our data was comparable in terms of background demographics. Over half of the women, so 13 out of the 21 that had HPSS, had similar rates of the painful crisis, so 42%. We did have slightly higher rates of acute chest crisis, although obviously understanding the numbers are small, so 10% versus that, almost 7%. Slightly higher booking hemoglobins of 95 compared to the 85 UCOS data, but similar rates of blood transfusion, so 19% versus 23% in the UCOS data. What we did identify the trend was this higher rate of preeclampsia, so 19% or 4 out of 21 women had diagnosis of preeclampsia. Over half had a baby that was born less than the 10th centile, and this 91% rate of caesarean section, with 55% undergoing a Cat 1 caesarean sections in those who had an emergency caesarean section. So I'm just going to go and talk about this kind of the placental dysfunction aspect of sickle cell disease, because I think that was the kind of one of the most interesting aspects of the audit data that we found. So as we've mentioned, so aspirin is recommended, as we know, to help improve placental functions. It helps remodel uterine arteries, makes a lower resistant uteroplacental circulation, and then it can reduce the incidence of early onset preeclampsia and fetal growth restriction. And that was through the ASPIRATE trial. There's no evidence for its use within sickle cell disease, but it's been extrapolated because of these high rates of preeclampsia that we should offer it, and it should work in the same way. But the thinking is that the underlying placental dysfunction that these women have is different, and it's this more that they're not having. It's not this early onset uterine artery Doppler failing to remodel that you would expect in someone who has early onset preeclampsia or FGR, but actually it's the chronic sickle cell. It's this hypoxic insult to the placenta chronically throughout the pregnancy that then causes the placental dysfunction that manifests in this way. So the top left picture is just a picture of a nice healthy placenta. So it's nice homogeneous grey colours, nice and thin, like a thin crispy placenta, thin crispy pizza, sorry, that we would describe it as. So it looks nice and healthy, good exchange across the placenta you would expect. Placenta below is a placenta that is a woman who's got sickle cell, so it's this chronic vaso-occlusive insult to the placenta, and you can see it's blobby, it's thick, it's got these white echogenic foci in it, suggesting that these kind of areas of hypoxia. And then this big picture, so it's placenta of a woman with sickle cell. So again, you can see this kind of abnormal morphological appearance of it, and then the measurement at the bottom is of the liqua, so oligohydramnios, which again is often seen in when you get placental dysfunction. So going back to the positive placental screen, so as I said, so in the women that had a placental screen, so not everybody had a placental screen that we audited. So out of the 15 women that did have them, 3 out of those 15, so 20% had a positive placental screen. Those women, so the bottom left graph is split into, so if you were born SGA, so less than 10th centile, normally grown or big, and the red dots are women who had a positive placental screen. So all 3 of those women had babies that were born less than 10th centile. But as you can see, there were lots of women who had a negative placental screen, so those green dots that were born less than the 10th centile as well. So there's obviously something we're missing in terms of that screening. The uterine artery Dopplers it's going to pick up the women that have that placental disease from the uterine artery Doppler perspective, but it's going to miss the kind of the sickle cell pathology essentially. And then this bottom graph is just this showing this leftward shift of the birth weights towards that kind of the lower end of normals. So just to finish off with a case example, so we had a 26-year-old lady, so this is a woman who was in the audit data set that we had. So 26-year-old lady, it was first pregnancy, she had HBSS, sickle cell disease, and she had a booking HB of 80. She had transferred to care from Blackburn at about 19 weeks. Gestation was seen in the Joint Obstetric and Haematology Clinic in January 23. She was referred to our placenta clinic, so she had a placenta screen, so this measurement of the uterine artery Dopplers at 22 and 6. Her screen was negative, so she had normal uterine artery Dopplers, normal umbilical artery Dopplers, normal estimated fetal weight. However, the placenta was noted to be bulky and small, so she remained under the placenta clinic for surveillance. She unfortunately suffered multiple admissions for vaso-occlusive crisis. She had 5 episodes of sickle cell crisis in that pregnancy. So kind of her last admission was at 30 weeks due to a severe crisis. She ended up in ITU and needed a 2-unit blood transfusion. Despite the blood transfusion, her HB remained around 50. About a week later, she started to develop a hypertension, so she was commenced on treatment with nifedipine. She had a growth scan which was normal, and she had normal like volume. We measured, we did a PET screen, so at our hospital we use a ratio of soluble FLT and placental growth factor, and she had a very abnormal one, so the upper cutoff for abnormal is 80, I think it's 84. Hers was 1,079, so a very high abnormal ratio. The placental growth factor itself, so anything less than 100 is abnormal, so 20, so it's low, but the soluble FLT is a lot higher than you would normally expect as well, so it's 21,000. So she's got placental dysfunction going on, and then about a week later she developed oligohydramnios on scan, and she underwent a Cat3 cesarean section. So, and this flow chart is just to kind of fit into that picture of, so this repetitive vaso-occlusive crisis, this low HB causing ischemic placenta, which drives this rise in the soluble FLT, which then competitively brings down the placental growth factor, get you endothelial dysfunction, and then this preeclampsia type picture. So, in conclusion, so pregnancy complicated by sickle cell disease experience high rates of maternal and neonatal morbidity and mortality, unfortunately. There are much higher rates of preeclampsia, FGR, and emergency cesarean section, potentially due to this placental chronic hypoxic pictures from these repeated vaso-occlusive events. The current tools that we use to prevent this, so the low-dose aspirin and to predict it, so the uterine artery Dopplers, are not specific for the potential underlying pathophysiology in women with sickle cell disease. So it's this role of increased growth surveillance and consideration of blood transfusion potentially for optimization around delivery. And then from our point of view, what our next steps are is we're auditing the whole antenatal patients from the past 15 years at Oxford Road. So we're going to have hopefully a case report of about over 100 patients to kind of interrogate this in a bit more detail. Thank you. Any questions?